Hi, good day. Thank you so much for joining us today. My name is Dr. Elaine Wan. I am Associate Professor at Columbia University. I am the Director of Electrophysiology Research as well as a cardiac electrophysiologist. I'm joined today with my wonderful medical student, Pavi Guttipatti, and today we will be discussing the 2023 Heart Rhythm Society Expert Consensus Statement on the Management of Arrhythmias During Pregnancy. So, Pavi, why don't you start off with some questions that you had after reading this document?
This document had many important points and information on it, but I'd just like to get your thoughts on why you think overall this consensus statement is important.
Yeah, I think first, really great kudos to Dr. Jose Juglar, who's a colleague of mine, and also the rest of the consensus statement committee, who really did a great job in formulating this consensus statement, which was much necessary. For me, this topic is near and dear to my heart because one, I'm a cardiac electrophysiologist, and two, because I am currently expecting my second child. So it was so nice to see that there is this statement about management of pregnant women with arrhythmias. So this consensus statement is really important because it ties together clinical practice as well as research from multiple disciplines. It includes electrophysiologists, obstetricians, neonatologists, as well as genetic counselors. It also provides up-to-date evidence-based recommendations and provides a unified approach to the diagnosis and management of arrhythmias in pregnant mothers. There are also a few strong randomized controlled trials in this population with much evidence coming from limited data sets. So the fact that they were able to categorize the different levels of evidence and digest this from all healthcare providers, I think was very important. And by performing an in-depth and comprehensive dive across the multiple fields, the authors have been able to create classes of recommendations and also provide the quality of evidence behind each recommendation. So it's clear for all healthcare professionals that might take care of pregnant mothers as well as their children. The guidelines have created a useful one-stop resource for information for a very broad topic of arrhythmias and pregnancies. And I think it's really helpful for all clinical providers of expecting mothers and their children.
Yeah, and reading through that guideline, even as a medical student, I found it very helpful just to get an idea of the different types of arrhythmias and their approach in pregnancy. And the guidelines also go into many different types of arrhythmias. Could you tell us more about what the common arrhythmias are in pregnant women and what the expert statement says about their diagnosis?
Yes. So I'm also a consultant for the Mother Center at our hospital at Columbia University, and I can attest that the most common arrhythmia or complaint that pregnant mothers have are palpitations, and that is to be expected because when you have a larger physical load on your body, there's more metabolic and physical demand. So palpitations are the most common cardiac symptom in pregnancy. However, only about a tenth of the time an arrhythmia is actually found on an EKG or a monitor at the time of symptoms. And most of these arrhythmias are benign, with sinus tachycardia and premature atrial ventricular contractions being the most common. And now we see that a lot more patients are using smartwatches or wearables, so we'll see that they catch more things such as sinus tachycardia. In these cases, if there are no concerning symptoms or underlying cardiac diseases, then these patients can just be provided with reassurance. Among the arrhythmias that do require intervention, the most common is supraventricular tachycardia. Ventricular tachycardia, ventricular fibrillation, and high degree V block are more rare, not frequently seen, and may occur in patients with pre-existing cardiac disease or additional risk factors such as congenital heart disease. The consensus statement was very clear in the recommendations that all patients that present with palpitations, they should, one, receive a detailed initial history and physical exam, which we should provide to all of our patients, a resting 12-lead ECG, targeting blood testing such as anemia, thyroid, or electrolyte abnormalities. And if there are concerning symptoms or any imaging that shows electrical or structural heart disease, ambulatory monitoring such as a Holter or vent monitor may be recommended. In the patients who have a negative workup but an arrhythmic cause is still suspected due to symptoms which may be recurrent or underlying structural heart disease, possibly the use of an implantable cardiac monitor may be a reasonable choice. The guidelines emphasize specifically that electrophysiology studies should not be first-line diagnosis. So just like in non-pregnant individuals, good clinical exam, history, and diagnostic testing and imaging is always first line.
Yeah, that step-by-step approach is very helpful. And then even after a diagnosis is made, the management of arrhythmias in pregnancy is also something that clinicians may have questions about. And the guidelines discuss how certain arrhythmias like atrial fibrillation are increasingly becoming more common. How should pregnant women be treated for atrial fibrillation, and what are the care practices in institutions for these women?
Yeah, I think that's a great question because one, atrial fibrillation, as you know, is the most commonest clinical arrhythmia that we see. And now with mothers who may be of higher expecting age than previously, atrial fibrillation is increasingly more common. So in the case of acute atrial fibrillation, the management of pregnant patients is similar to non-pregnant patients. Number one, if there is hemodynamic instability, the guidelines are very clear in recommending that cardioversion should be the first line of therapy. Cardioversion is safe. And so I'm going to repeat that one more time because I think it's a very important message that cardioversion is shown as safe and the same energy levels can be used in pregnant patients. I think the guidelines was very good in that they had very nice figures and images for practitioners to look at. And it's important to note that in figure 4 of the statement, it shows the appropriate location of placements of the electrical pads for defibrillation and cardioversion. Defibrillation should be placed in the sternal and apical position, the left side, as for defibrillation of ventricular tachycardia or ventricular fibrillation. Cardioversion, such as for atrial fibrillation or hemodynamically significant supraventricular tachycardia, should be an anterior and posterior placement. We should avoid any proximity to the belly and avoid breast tissue because you really want the cardiac tissue to be captured. For hemodynamically stable patients, the first line therapy is intravenous beta blockers. Various beta blockers are covered in the guidelines and deemed safe of use. Labetalol and atenolol may cause fetal growth restriction, and it should be mindful that nadolol may be excreted in breast milk. Second line options are intravenous calcium channel blockers or digoxin, or in combination of both. Another caveat is that calcium channel blockers may cause some vasodilatation or relaxation of the uterine wall. When these agents are unsuccessful, then cardioversion is recommended with ibutylide or flecainide, and those were thought to be a class 2A in conclusion. Safety and efficacy of these medications mostly based on case and database reports. Similar to non-pregnant patients, if there is pre-excitation on the 12-lead EKG then is present, then beta blockers should be avoided. And definitely an expert cardiac electrophysiologist and cardiologist should be called to assist. Acute management of these patients may not need continued therapy, but there should be appropriate follow-up. The guidelines suggest that beta blockers, calcium channel blockers, or digoxin alone or in combination may be needed, followed by flecainide or sotalol. If a patient is experiencing recurrent unstable atrial fibrillation despite these medications, then catheter ablation or amiodarone may be a last resort and trialed, and these are all class 2B recommendations. Anticoagulation in the setting of atrial fibrillation should follow the same CHA2DS2-VASc risk factors at non-pregnant patients. And the score has unfortunately not been validated in pregnant patients since atrial fibrillation in pregnant patients overall is still rare. And the level of risk added by the hypercoagulable state of pregnancy is unclear. Invasive procedures such as AF ablation should be performed in centers with experience in limiting the use of radiation. Nowadays, we have 3D high-density electroanatomical mapping that really limits the amount of radiation that a patient needs to be exposed to. So that may be considered as a last resort if medication is not managing the patient well.
Among all those guidelines, there definitely seems like there are lots of tough decisions that clinicians might be faced with. And those are discussions that might need to be discussed with both the mother and with other care team members. How should shared decision-making be approached in these situations?
Yeah, thank you so much for bringing up that question, because I think one of the highlights of this document is emphasizing the importance of interdisciplinary care and also shared decision-making, because when we're making a decision for the mother as well as the child. And really, it requires the expertise of the obstetrician, the anesthesiologist, the cardiologist following the patient. And sometimes it may also require the expertise of the pediatric cardiologist following the fetus. So shared decision making amongst all these parties is very important. So given the limited evidence available for certain management decisions, shared decision making between providers and patient is extremely important. Number one, the risk and benefits of pensional therapy should be clearly stated, including the effects on both maternal and fetal health, and the discussion of possible exposure of the mother and fetus to side effects. Once patients are well informed and preferences explored, joint agreement can be reached. It also emphasizes in this guidelines the importance of across disciplines and continued discussion between all the parties that are involved in the care of the mother and the fetus.
Okay. So we've talked about arrhythmia management a good deal from the maternal perspective. How about fetal arrhythmias? Which ones should be considered concomitantly, and how would they be approached?
Yeah, so this question I took as to, first, how should you manage maternal arrhythmias, and then subsequently, how do we manage fetal arrhythmias? And in some cases, they're one and the same, because whatever you're going to give to the fetus to treat the arrhythmias, the mother may be affected and vice versa. So as we talked about atrial fibrillation, management of arrhythmias is similar to non-pregnant patients with certain considerations. The guidelines provide detailed recommendations for multiple types of arrhythmias, such as SVT, supraventricular tachycardia, ventricular tachycardia, atrial fibrillation. And the guidelines provide detailed recommendations. The most important thing is that invasive procedures are noted to be safe in the setting if all the medical therapy is not useful. Some categories of procedures, such as catheter ablation device device implantation, can be performed to minimize radiation exposure to the fetus. Some of the guidelines may include research studies that the radiation dose in women undergoing SVT using a human-like model, and that radiation exposure can be well below the threshold for lifetime malignancy risk. Considerations for treatment of arrhythmias and maternal and fetal arrhythmias is that arrhythmias in pregnancy can affect both mother and the fetus. It involves either maternal systemic delivery of antiarrhythmic agents, and they rarely have any direct fetal intramuscular injection or intraperitoneal injection. Fetal arrhythmias may prompt collaboration with pediatric electrophysiologists in imaging with fetal echocardiogram or monitoring of fetal heart rate. So all these things are need to be considered, and that in the case where an invasive procedure such as electrophysiology study or device implant needs to be done, one important notation of this consensus statement is that the technology of 3D electronautical mapping can allow for low or zero fluoroscopy, and that what was thought to be used, that was used in the past, such as a lead apron over the pelvis, is not actually recommended, since most of the radiation comes from chest scatter. And there's a possibility that the lead can increase radiation output and dose to the fetus. So it's recommended against just putting a lead skirt on top of the abdomen. But most importantly, to work in a group with experts who have experience with working in a setting with the lowest amount of radiation exposure to deliver meaningful outcomes.
We've talked a good deal about the sort of management that's best during pregnancy. How about in the postpartum period? Are there certain drugs that should be considered differently during lactation?
Yeah, I think that's a great question, because often when we're taking care of the mother, we think about the mother and fetus, but we don't think about after delivery. So antiarrhythmics that are used in which concerns about lactation, risks and benefits should be considered. Drugs that pose medical risks for breastfeeding include digoxin, propranolol, metoprolol, and verapamil. Drugs with favorable safety profile, despite limited evidence, include carvedilol, esmol, procainamide, diltiazem, flecainide, and sotalol. Amiodarone should be avoided whenever possible and should be used as a last resort. There is no data on dronedarone or butylide, and therefore not recommended based on these guidelines during lactation. It is important to educate parents about the signs of toxicity in infants, and in select cases, even serum levels from the infant may be necessary, for example, when using high doses of flecainide. So I think this is a great question, and that should definitely be thought of after taking care of the patient in the acute phase in the delivery of the baby, about what drug should be appropriate when the mother is breastfeeding.
Okay. The guidelines also do a great job of going into very specific conditions that patients may have, both the mothers as well as the fetus. What are some of the insights that you take from the recommendations on like long QT syndrome, Brugada, or catecholaminergic polymorphic ventricular tachycardia?
So all these different conditions that you mentioned, like long QT, Brugada, or CPVT, catecholaminergic polymorphic ventricular tachycardia, is rare, very rare genetic conditions. And most of these patients, hopefully, have been diagnosed prior to their pregnancy. So they knew that they had this condition, or followed by a physician who knew about their condition. So long QT patients can continue their beta blockers. Long QT2 patients usually continue their postpartum nadolol or propranolol. And once again, I'm going to mention that nadolol need to be careful during lactation because of its excretion in breast milk. Genotype positive long QT patients may still get a beta blocker depending on the recommendation of their healthcare provider. Brugada patients should avoid fever. Their medications should be checked to avoid long QT. Patients with catecholaminergic polymorphic ventricular tachycardia should continue their beta blockers. They may be on flecainide as well as the beta blocker, and perhaps in the past they may have had a cardiac sympathectomy to avoid adrenergic surges. Any type of epinephrine should be avoided in these patients, and if they happen to have a defibrillator, their defibrillator should be programmed to provide minimally triggers to avoid an adrenergic ventricular tachycardia storm. So usually these patients are already well followed by a cardiac electrophysiologist. If they aren't, then it's the right time to make sure that they are, to bring an electrophysiologist on board to take care of this special patient population.
Okay. And then finally, one decision that holds a lot of weight is whether patients should be on anticoagulation or not. And we talked about this a little bit with atrial fibrillation. What do the guidelines say about when patients should be on anticoagulation, and what sorts of medications should be used?
Yeah, that's a great question. And always taking care of a pregnant woman who requires anticoagulation has already been tough because there's limited number of medications that we can use. In the past, it was just either heparin or Coumadin. And usually these patients are either one, have a high risk of a hypercoagulable state, or they have some sort of prosthetic heart valve. So anticoagulants should be based on their CHA2DS2-VASc score. As mentioned previously, we don't know about pregnancy as a hypercoagulable state, how to factor that in. So currently we just use the CHA2DS2-VASc score. Unfortunately, today, a lot of their patients use direct oral anticoagulants, but they cannot be used in pregnancy or breastfeeding. If a mother has a prosthetic valve, then the goal INR should be based on the mechanical valve pregnancy guidelines and should be transitioned from heparin as appropriate. So as is, there's no changes really for patients, how they were treated for their anticoagulation prior to their pregnancy as compared to during and after their pregnancy.
All right. Thank you so much for your insights into these guidelines, Dr. Wan. That was all very helpful.
I do want to mention one other common diagnosis that pregnant women get, and that's syncope, because syncope can happen in 1% of pregnancies. Syncope is a transient loss of consciousness due to hyperperfusion, and pregnant patients who experience syncope in the first trimester have a higher risk of adverse maternal fetal outcomes, including recurrent syncope. So workup is important for these patients. And the workup should include a detailed history and physical, a 12-lead EKG, as well as orthostatic vital signs. An echocardiogram and event monitoring should also be done. Those with recurrent syncope may warrant an insertion of a loop recorder for diagnosis. Orthostatic hypotension is common in third trimester pregnancy, and that's because the gravid uterus causes anatomical and positional stress, such as compression on the inferior vena cava, and results in decrease of return of blood to the heart, and other factors such as hypovolemia, like not intaking enough water, autonomic dysfunction, and vasodilatation from the pregnancy hormones. So patients with typical symptoms of vasovagal syncope after a normal physical exam and workup do not require further testing. And also, once again, a key point of the consensus statement is that diagnostic electrophysiology study is not indicated in vasovagal syncope with a normal physical exam and normal imaging, because this is expected to happen due to the physical constraints of pregnancy that affects physiological function. So that's also an important point, I think, to take home. But thank you so much, Pavi, for interviewing me today and highlighting the key take-home statements of this very important consensus statement. Thank you to Medscape for giving us this opportunity to discuss this wonderful statement that was prepared by the Heart Rhythm Society and also the collaborating societies. It really took a Herculean effort between the obstetricians, electrophysiologists, and all the other players, the pediatricians, maternal fetal medicine, in coming out with this much needed consensus statement. Thank you.